Well, before we get started, I'd like to reinforce the concept that what we're looking at now are slides of the cases that I hope you did preview on the workstations. If you did, you'll know that a lot of them have very subtle findings. And to see subtle findings, you need to be as close to the screen as possible. If you're sitting too far back, I'm going to be talking about things you will not be able to see. So I don't call on anybody. It really makes a difference to get close. So you're free to move if you want. And I think you should. If you have to leave before we're finished, don't worry about it. It doesn't matter. Certainly not to me. I understand about the need to catch planes and things like that. Next piece of information. There are 20 cases. I'm going to go through them in the same sequence that they were on the workstations. There's a number in the upper left corner which is going to show you what case you're on in case you lose track, and also to help me so I don't lose track. We're going to start out each case with a history. It's the same history that you're provided in your booklets. Keep your booklets open to the page that we're doing. And as we go through the cases, as you'll see, and actually I'm going to start looking at what I'm seeing on the screen. What you see here is the same thing. Each case will proceed in the same fashion. The first image that you see will be the current exam. If the breast is small enough that I can fit all 4 images on one slide like this one, you will see it like that. If it isn't so small, then you will start out with a pair of MLOs of the current exam, followed by the CCs of the current exam. So this gives you a quick opportunity to refresh of what you are looking at, but start out the case by looking at what you commented on your page. Next thing I'm going to do is I'm going to show you the breast of interest, which is, in this case, the left breast. And the next thing I'm going to show you is where the lesion is, which is there. This is the time when you look at your syllabus and see whether you put a mark in approximately the same location. Hopefully you did. And then we are on the same wavelengths, because that's what I'm going to be discussing. There are a few cases where there's more than one finding, so you may have marked one and I'm talking about another, and just wait until the end of the case to see whether the one you marked is the more important mark. Having done this, we're now going to go into a discussion of the case. I've showed you where it is. In this case, it's an asymmetry. It's only on one of the 2 views. And the next thing I'm going to show you is a full pixel image of the finding. This has 2 purposes. The first purpose is to show it to you better so that you can see it a little bit better. Again, notice how small this is. If you're in the back of the room, that's a dot. The second thing is to remind you that when you're working at workstations, you absolutely must look at every finding that you're considering at full pixel resolution. If you look at it at anything less, you are missing some of the information that has been recorded on the image, and you are held to a standard medical legally of doing this. So if you don't do it and you miss something, it's not going to be so easy to defend you if you're involved in a lawsuit. It's also not the best thing for your patient. Okay, so at full pixel resolution, this asymmetry has a somewhat indistinct margin, which might make you a little bit more concerned. You notice it in this very dense breast because it's so bright, it's so white. And cancers often look whiter than similar sized areas of fibroglandular breast tissue. So there's some reason to be concerned. On the other hand, it's a one-view finding. It's an asymmetry. We know from yesterday that more than 80% of these turn out to be summation artifact. So what is our goal here in working up this case? It's to first figure out whether it's real. If it's real, then you go on from there. In the 80+% where it's not real, you're done. It's negative. Okay. Next thing we're going to do is we're going to compare it with the previous exams. And remember from yesterday, when you compare with previous exams, if the finding is there and then it's not there and then it's there, that's the hallmark of superimposition. What do we see here? We see the finding. We see maybe a little bit less of the finding, but it's not even sure that's the same thing, and then we don't really see anything. So this is consistent with either a summation artifact where you see it and you didn't see it, or maybe a slowly growing lesion where you do see it. It's indeterminate. If there had been other older priors, since now in your head at least you're contemplating recall, then you should look back at the other ones. Because if you can find it on any one of the other ones, that will demonstrate that it's superimposition. See it, don't see it, don't see it, don't see it, see it is superimposition. In this particular case, we didn't have any other priors, so we're going to recall her. And what I'm going to show you here is the 2D approach to working this up, because that's what was used in this case. A TOMO approach can also be used, and it works almost as well. The 2D approach involves repeating the same view where you saw the finding, in this case the CC, and getting a spot mag of that finding in the same projection, like that. These two in combination give you a dual opportunity to see a real finding and give you the other opposite opportunity to be confident that there is no finding there if you don't see anything. In this particular case, this is not visible in the same location, and you only have to look in the same location as you had before. If the pictures are taken, the images are taken in almost the same projection, you will know exactly where to look because you have landmarks. This is the same as this is the same as this area here is the same as this. Our finding has got to be in this very small area here, and it's just not there. What about on the spot mag? The spot mag is taken with the X-ray beam. The positioning may be the same, but the X-ray beam is more divergent because it's a spot mag. And things are not going to overlap quite the same way, which is another advantage of having the spot mag. And also the advantage is you have a fine detail image if you do see it, so you have a better chance to characterize it. Again, here, our finding has got to be somewhere in this area. We know it's within the spot, and we don't see it. Well, what does this mean? In my experience, I can't speak for my colleagues because I'm not there while they read, but in my experience, having done this thousands of times, every instance where I don't see it on those two images, it's a superimposition. It's definitely not a breast cancer. So this is a 100% reliable way of establishing superimposition if you recall a patient. It's not the only way. You can do TOMO. If we had done screening TOMO back at the screening exam, we might not have had to even think about recalling her. If we hadn't done TOMO, now is a good time to do one instead of this. Or if you're not sure, in addition to this. And then that will also help you decide whether it's real or superimposition, because the superimposition on TOMO is apt to spread out as you go through that part of the image. If, on the other hand, with any of these approaches you still see the finding, then the workup continues. Well, in this case, the workup should stop because there's nothing there. And since there are no findings on the current exam, the appropriate BI-RADS assessment for the diagnostic exam that you've just started is BI-RADS 1 negative, because there are no findings. You should add a sentence saying that the finding seen at screening was found at fine detail imaging to be superimposition of normal structures. And that's it for the case. At the end of each case, I took longer on this one than I will at some of the other ones, but at the end of the case, if any of you have questions, I'd like you to ask them now rather than waiting for the end of the whole session when we do have time for questions and answers. Because if you ask a question about case 1 and we're at the end, I have to go all the way back in the slides to case 1 and find it. Whereas if you ask now, we're right here. And we'll have enough time for questions, and I urge you to ask them now. So, yeah, go ahead.
Within the right breast on this case, it looked to me like there was architectural distortion in the upper central.
Okay. Okay, well, if you didn't hear, he's asking about a potential finding in the opposite breast. I didn't mention it at the introduction because this question always comes up. What about, you talked about this, but what about that? And the answer to that is, I hope you're wrong. Because we didn't work it up. If we had worked it up, I would have mentioned it. So, I don't know. I can go back to it, but you're going to have to try to explain to me where this finding is. Let's see. I want to hit this button here. The workstations are still there, and you can go back and look. Let's see. I'm hitting the wrong buttons. There we go. Okay, this is the only view you've got of the opposite breast. Which projection?
On the MLO, upper central, posterior depth, mid to posterior depth.
This?
And on CC, kind of central.
Here? Here?
There's a larger area, that area there.
Well, I don't have a close-up of it, so I'm not going to be able to tell you much. But the answer is I can't say. I'm sorry.
Actually,
yeah.
the residents ask about breakfast a lot. I think one of those through it, you check, is it truly distorted white stuff or distorted stuff?
Okay, well, there are white lines and black lines, and we're more interested in the white lines, but I don't know what you're looking at.
In this case, I remember noticing that, and I thought it had been stable. You had a couple of prior years. I didn't see.
Yeah, okay, that's the other point. And the other point is, if you notice on the current exam and 1 year ago and 2 years ago, it looks the same, then it's a real finding, but it's also something that hasn't changed. And if you've got a architectural distortion indicating a cancer, it's usually going to change in 2 years.
And I thought it was differences in position.
Yeah, so...
I did notice the roundo in the medial left.
Aha, see, now we got a third lesion. Okay.
Medial left, that little roundo that you were working up.
Uh-huh.
But during your workup, I'm thinking, with so much dense breast tissue, even though it looks like it resolves on the repeat view and the spot mag, I think I'd be too scared to not do an ultrasound on top of it and just let it go. Again, only because it's such dense breast tissue. And of course, we probably would have had 3D. But,
Okay, so...
the point I wanted to make was, you taught me 2 decades ago that when you're not sure about proceeding with a new form of doing something, like multiple bilateral breast masses, go ahead and recall it, work it up the way you would, take a note of the medical record number, and 1 or 2 years later, go back and see if you could have let it go.
Right.
And that's how I changed my practice over time, and that's what I do with this case. keep a note of the medical record number, I'd recall her for sono, but then I would do the new workup, and 2 years later, see if I could have done it that way.
Right, and that's a very good approach. I'll get to you in just a second. Excuse me. Now I lost my train of thought. I agree with everything you say. And the one caution I would make is that ultrasound evaluation of a one-view finding is very tenuous, because you don't know exactly where it's located in 3 dimensions, if it's real. So you have to scan pretty much half the breast. And number 2, if you see something on the ultrasound, that doesn't mean that it's the same thing that you're looking at here. So basically, if you bring her back to recall her because you just want to feel a little better about it, what you're doing is a screening ultrasound. You're not doing a diagnostic exam evaluating that finding. You're doing a screening ultrasound looking for something else. And that may be what you want to do anyway, because it's dense breast. So there's nothing wrong with that approach. It's fine. Okay, someone here had a question. Yeah.
I just want to make a comment. That most of the time when we screening kind of breast, we already go with tomosynthesis. And with tomosynthesis, we rule out.
Yes, exactly. If you have tomosynthesis and the patient has agreed to have it done, we try to do it on all of our patients, but some of the patients don't want it, so we don't do it. But if you have tomosynthesis, you've done it, you're going to have fewer cases where you even think about recalling her, because on the tomosynthesis, when you look in that area on the 2D and you go through the different frames or slices, you won't see anything. It'll just spread out, and it'll be normal. The other point to make is, if you've done that and you're still not sure, because sometimes you're not sure with the tomos either, then you recall her, and when you bring her back, you can do spot compression tomo, which it gives you a sharper image. So you can do all of these things. And whichever ones you choose to use, and any other things that you can think of, are fine. I'm trying to teach you the most efficient way, time-efficient way of doing it, which to me is just taking the 2 pictures and you're done. And in the 80% plus of cases where this happens, it's a very brief diagnostic exam. The techs love it because they get to catch up with the more difficult cases, because this one's only going to take 5 minutes. Okay, we're going to move on to the next case. So let me get to number 2. There's number 2. Okay, this woman is asymptomatic. The extra stuff is just to tell you, don't worry about the radiopaque markers, because they're skin lesions. All right, here's a pair of MLOs. Here's a pair of CCs. Now I'm going to show you the breast of interest, which is this breast. And now I'm going to show you the finding, which is that. And now you can look in your book. Again, this is an asymmetry case. It's one view. This one's a little bigger. It's a little easier to see, which may or may not be good, if it's a fake out or if it's real. Here it is at full pixel resolution. You can see it a little bit better. It has a somewhat indistinct margin, which again might be of some concern if it's real. Ignore the vascular calcification. Look at the priors. In this particular case, our finding, which is here, looks like it might be bigger than there, and then maybe not even existent back there. This is another one where it looks like it could be growing. If you had older ones, you would look, but we don't have older ones in this case. So again, here you're going to recall. This case worked out differently than the previous one because here on the repeat you can see it again. And it looks the same. And what does this suggest? Well, there are two explanations. One is you managed somehow by really bad luck to take a picture of exactly the same as you had before, and it looks like it's real, but it's still really a superimposition. That's highly unlikely, but it's a possibility. The much more likely thing is that it's real. And you've managed to see it again because even though the projection isn't exactly the same, things don't have to overlap in order for a real finding to still be visible in the same location. I didn't show you the spot mag, which we also would have done, but it was visible there. So just for the sake of time, I didn't show it to you. What are we going to do now? The next thing we're going to do is we're going to try to find it on the true lateral because we now suspect that it's real. And if we saw it on a CC and we can see it on a true lateral, we know exactly where it's located. We're ready to go for the ultrasound because we know exactly where to look for it. And it appears that it is right there. So now we know we've got a finding. And once you see it on two projections and you've got a rounded convex outward finding that's denser in the center than at the periphery, you can call this a mass. It shifts from a workup of an asymmetry to a workup of a mass. And what do you want to know next? Well, if you've done TOMO, you get a really good look at its margin. If you haven't, you can. If you don't have TOMO, you can do spot mags, and that will give you another indication of its margin. This particular patient had spot mags. And most of the ones in our practice will have TOMO because most of our staff radiologists prefer that workup. But they're both equivalent. And you'll want to do ultrasound, especially for a non-calcified mass. Most people would do ultrasound first, and that makes sense. For a non-calcified mass, ultrasound before mags. Why? When you think it's real. Why? Because ultrasound, if it shows it's a cyst, will stop the workup and you don't need the mags. If you start with the spot mags, you still don't know whether it's a cyst, so you always have to do the ultrasound. So do the one that can stop the workup potentially first because it's more efficient. And you just don't have to take extra images that aren't necessary. This is not a cyst. It's a hypoechoic solid mass with indistinct margins. This is suspicious. But again, a real finding that's growing even without the ultrasound is suspicious. One of the purposes of the ultrasound is now we know that when we do the biopsy that she needs, we can do it with sonographic guidance. Okay. We did a sonographically guided core biopsy, and this image simply shows you that we biopsied from the correct location and the area where we thought the finding was on both images. You always want to get a picture like this to validate that you biopsied in the right place. And if for some reason your clip is not where it should be, then you have to make a decision of whether this is the accordion effect and you really did biopsy in the right place, but when the breast expanded out of compression that the clip moved a little. And the answer to that case was that this was invasive ductal carcinoma and DCIS both. So this is an example of a one-view only asymmetry that turned out to be a malignancy. Questions? Not seeing any, we move on to case 3. Asymptomatic woman. Before I go on with this, some of the slides are going to look very high in contrast. That's because this particular equipment manufacturer produces higher contrast images. On the workstation, it looks fine. The workstations are quite capable of adjusting for these differences in image quality so that you have a perfectly interpretable image at the workstation. But slides are more difficult. So when you see slides like this, it just means it was a high contrast image, and the slides aren't good enough to be able to show it to you with the correct grayscale. At any rate, you can still see the findings. So here's a pair of oblique views. Here's a pair of CC views. This is the breast of interest. The finding is here, but you're probably not going to be able to see them, even if you're in the front row, because we're talking about small calcifications. On the other hand, this is where you want to look on your pages to see whether you've marked that location. And now I will show it to you at full pixel resolution. If you're close enough, you probably will be able to see that there are some calcifications in the center of the dotted line circle. When I annotate my images on the slides, if it's reasonably readily visible, it'll be a solid line. If it's a little bit less visible, it'll be a dashed line. And if it's really hard to see, it's going to be a dotted line. So this is a clue to you that this is hard to see. You can see it on the workstation, but it's really hard to see on the slides. You can probably see there are a few little white dots there. Is this of concern? Well, if it's the only area with calcifications, yes, it is. And that would prompt a recall. On the other hand, when you're contemplating recall, you're going to want to see what happened over time. In this case, we only had one prior, and when you look back at the prior, it looks like there are more calcifications now than there were last time. And since they're in a group and they're increasing in number, this is something that would prompt recall. And it did, fortunately. And the first thing we're going to do on this is we're going to do spot mags. We are not going to do ultrasound first on this. The spot mags, if they showed some typically benign thing like layering calcifications, that might stop the workup. And we wouldn't need the ultrasound, unless you wanted to do screening ultrasound because she's dense. In this case, when you look at the calcifications, most of them are round in shape, which might be consistent with probably benign finding. Some of them are amorphous, which isn't so consistent with a probably benign finding. But it's not going to be a probably benign case if the calcifications are increasing in number, because then you already have a demonstration of growth. Remember, when you're contemplating BI-RADS-3 as an assessment, and you have priors, the priors are almost always going to take you away from BI-RADS-3 into either a 2 or a 4. Because if the lesion's getting better, it's a 2. If the lesion is stable and you've got 2 to 3 years of follow-up, it's a 2. And if the lesion is getting worse, it's a 4. So anytime you've got priors, you're probably not going to use a 3. In this case, it would be a 4 because they're getting more. There are more of them. The other purpose of getting spot mags is to determine the morphology of the calcifications better, because you're going to see them in finer detail. And you might see morphology that leans you towards benign or suspicious. And the second reason is that it will help you see the extent of the calcifications. It is not uncommon on spot mags to see calcifications over a greater extent than you saw on the conventional images. And that will mean that if you're going to be doing biopsy, that you may want to biopsy from the edges of the lesion rather than just from the center of the lesion, in order to demonstrate that if it's cancer, that it's cancer at the extent, because then when it's excised, the surgeon knows how much to take. All right. And where's my, and here's the answer. All the cores are lumped together here, but if you look carefully, you will see that there's calcifications. There's some here, there's some here, there's some here. That doesn't mean they're that far apart. That's just because they're all all lumped together. And this turned out to be high nuclear grade DCIS. So subtle calcifications is part of the hallmark of this. If you didn't see it, you just weren't looking that carefully, or maybe, unfortunately, you skipped looking at the full pixel resolution. These might not have even been visible on the images looking at the whole breast, and they certainly wouldn't have been visible looking at the initial images where you saw the current exam compared with the previous, because then all the images are so small that pixel averaging has probably wiped out the visibility of anything there. Anybody have any questions? No? Then we're going to move on. And we tend to go faster with the later cases, so don't worry about running out of time. All right. Okay. Case 4, dense breasts. Most of these cases are going to have dense breasts because they're hard cases. This is the breast of interest, and that's our finding. I've marked it as with a full circle on the CC where it's more readily visible. Here it's a maybe. And what this means is it's predominantly a one view only finding, but I think maybe I see it on the other view. If you have the opportunity on your workstation to annotate images the way I've done on the slides, that's optimal, because you're telling the next radiologist, I want you to work up the CC, but I think if it's real, it's probably going to be where I see it on the MLO. If you just have to make the same circle and you don't have that opportunity, you can put in the report that you see a finding on the CC view, describe where it is, and if it's real, it may be visible in the superior aspect of the breast on the oblique view. You can put that into the report if you wish to help the next person. But annotating it is very important for the next person if you're going to recall, because they need to know what you're looking at. If all you do is recall and say, I see something and I think it's in the outer part of the breast on the CC, and the next person who's doing the diagnostic workup looks at it and says, he looks at me, well, I'm not sure. Were they looking at this, or were they looking at this, or were they looking at this? And they wind up having to work up multiple areas and not even be confident that they're looking at what you were looking at when you did the recall. And then you get really annoyed at whoever did that because they forgot to put the annotation on, and you go back and look at the report to see who you're going to chew out, and you notice that it was you. So always annotate and save the annotations. Don't let them go away. All right. So here's our finding, and when you look at it up close, there's suggestion of distortion, especially on the CC view. There's little lines coming out from it, and that's suggestion of architectural distortion. I like at screening to use the word suggestion, because I like to give flexibility to the radiologist who's doing the diagnostic workup to say, no, there's really nothing there. If I say there is architectural distortion, and then the next person is, with better images, concludes that there isn't, they may feel a little bit uneasy about not totally contradicting whoever did the screen, because ultimately they don't want to be at the wrong end of a lawsuit where one of your colleagues said it was abnormal and you're saying no. The person who's doing the diagnostic is the one to make the answer, because they have the better quality images. They have the opportunity to get as many images with as many technologies, as many modalities as is necessary to come up to an answer. So try to get, when it's not a clear-cut finding, think about using the word suggestion, because it just makes it a little easier for them to say, no, I don't think it was there. You'll appreciate it when you're at the diagnostic end. The other thing to note is that architectural distortion is a more concerning finding than just simple asymmetry. Architectural distortion is more worrisome enough to think about a recall if you see it on only one view at screening. It's not uncommon with invasive carcinomas to see the distortion on only one view. So don't say, well, you know, it's a one view finding, it's distortion, I can see lines crossing all the time. If you think there's distortion there on one view, you should recall, because the likelihood of cancer is going to be higher than the less than 20% that I quoted just for asymmetry. Unfortunately, we don't know the number. Nobody's written an article to give us that number, but it's higher. Okay, so I moved those images over to the right side of the slide because I'm going to show you comparisons. So that's the current one, and here are the previous ones. And it's hard to see this finding on any of the other images. So what does this mean? It means I see it now, I didn't see it before, I don't have any other older ones that show it. It means recall. Okay, we're going to do the same thing, although we could have done it with Tomo. I probably would have preferred to do this one with Tomo, because Tomo shows distortion better than any 2D image. If you're trying to work up distortion and you have Tomo, you should use it because it just shows things more clearly, because you're able to look at individual frames or slices and all the superimposed stuff that is no longer in the way, and if they're really radiating lines, you'll see them better. And for that matter, if you compare the CC repeat with the CC Tomo, you will see it much better on this one. If you want to write it down and go back and look at the case, it's on frame 47 of 79. You can write it down and go back and look at it. You'll see it on the workstation better than I can show you on the slide. Okay, now we need to find it on another view. And again, I would go to the true lateral first, because if you find it, then the workup's done. And in this case, we were able to find it. Okay, so this is going to be suspicious. Now we know where to look for it, so what are we going to do? We're going to do ultrasound. Why? It's not going to stop us from doing a biopsy, but it will tell us whether we can use sonographic guidance, and also whether there's another lesion. And in this case, there was one. We know where it's located. Whoops. And we can do the biopsy, and this was invasive ductal carcinoma, subtle. Just a point, if you didn't get one of these cases and it turns out to be cancer, don't obsess over it. These are very difficult cases. The fact that I'm showing to you means that one of our staff radiologists was fortunate enough to have detected it, but that doesn't mean that we detected everything. I'm only showing you our successes. Although that isn't completely true, because I'm going to show you a few of our failures too. And you may wind up having found something that we didn't find until the next exam. So I don't want people going home and saying, oh my goodness, there were 20 cases and of those there were a certain number of cancers and I only got half of them. Well, that doesn't mean, I'm just showing you our successes. That doesn't mean we all would have gotten them either. I don't want you, have any of you done Tabar workshops? When you do his workshops, a lot of people leave those saying, my God, I have to go back and do another residency. That's not the point. The point is, these are difficult cases. You don't have to get them all right, because very few people will get them all right. I'm not sure if anybody's going to get all these right, because some of them are really tough. All right, case 5. Here are the MLOs. Here are the CCs. This is the breast of interest. And there's our finding. Again, seen better, this one better on the MLO than the CC. Usually you see things better on CC than MLO because you have better compression on the CC because there's not any meaningful pectoral muscle included in the image field. On the MLO, there's a lot of pectoral muscle in the image field, and since we're using uniform thickness breast compression, most of the force is applied here and less force is applied here, so there's a chance for some very slight motion blur. Okay, so what do we see here? We see what looks like it's going to be a focal asymmetry. We see it here, and probably we see it there. That's why they're dashes, but we're not completely sure. So it could be a one-view finding. When you look at full pixel resolution, again, it looks more like an asymmetry than a mass. Concave outward, concave outward, concave outward, concave outward. Here it's harder to tell because it's not sure that you even see anything. But that's the full pixel resolution. Let's look at priors. Here are priors. This could have been there, and who knows what there. This, even less likely visible. It looks like it could be enlarging. So this is suggestion, if it winds up being a focal asymmetry, that it's really a developing asymmetry. And whether you can use the word developing or not, it's still a developing asymmetry. You just don't have to put it in the report. But it means that you recall it. Okay, repeat MLO, finding still there. Strongly suggests it's a real finding. Find it on another projection. Here it is on the MLO. If you're not sure it's the same finding, triangulate it. If you have the nipple at the same level on all three views, you should be able to draw somewhat of a straight line in between the finding on all three views like that. I don't know if I have a picture with a line. Oh, look at that. Beautiful. There's the line. And that validates that this dash really should have been a circle. And it also tells you, looking at the same finding, you know exactly where it's located. Then the ultrasound becomes easy because you know exactly where to scan. And generally, you will be able to find it. If it's really small and really subtle, it might be very difficult to find it. And what do you do if you can't find it, but it's still suspicious? You do a stereo. But usually you'll be able to find it, so you'll do an ultrasound-guided core. She had the ultrasound-guided core. This was invasive ductal carcinoma. Questions? This is case 5, I think. None? Here, just post-core biopsy images. Sometimes I show them to you, sometimes I don't, but we always get them, and we want to make sure the clip is in the right place. And you want to know that now, at the time of the core biopsy, because if she's coming back for excision and you want to localize that for the surgeon, you want to know where the clip was at the time of the biopsy. Okay, so this is number 6, case 6. This woman's had previous reduction mammoplasty, both sides, so we're going to see scarring. Although this is one of these high contrast cases, there's obvious scarring there, although probably you can see it on both sides when you're working at the workstation. This is the breast of interest. And here are some calcifications. You're not going to be able to see it from where you're sitting on these, but maybe you will on the full pixel resolution images. There are calcifications in a line, linear distribution of calcifications. What does calcifications in a line suggest? It suggests two things. One of them is vascular, which is definitively benign, and the other one is inside a duct, which is of concern, because calcifications in a duct could easily be DCIS. So what you need to do, first of all, is see how long they've been there. If they've been there, looks the same for the last 10 years, it's going to be vascular. If they are getting worse, then it could be DCIS, and you're going to be much more concerned and you're going to recall her. Why is the slide? Oops. Okay. I guess we didn't have priors, or I'm not showing you priors. I don't remember what the first slide said, but this woman got recall. And here are the spot mags. And on the spot mags, you will always see the calcifications better. If you don't see calcifications better on spot mags than you did on standard views, then either the patient moved and there's motion blur and you have to repeat it, or if you keep repeating it and it's not just this patient but multiple patients where the spot mags don't look so good, you need to have your physicist come in and check the size of the small focal spot on your mammography unit, because when mammography units fail, often it's the small focal spot that fails, because that's where photons are concentrated in a small area and it tends to be pitted. And if that's the case, you need to replace the tube. Okay, well, at any rate, we see them better. The morphology of the individual calcific particles is also linear. It's not just linear distribution, it's also linear morphology. And that's very suspicious for malignancy. So this is going to be suspicious. It may not be, what do you call it, highly suggestive of malignancy by RADS5, because it's probably not, just seeing that without any other findings is probably not enough to get you to 95% likely malignant, but it certainly would be a 4C in terms of how suspicious within category 4. So she's going to have a stereo. We might, in a woman with dense breast, do ultrasound anyway, not to look at the calcifications, which you probably won't see, but to see whether, because there's all that dense tissue, whether there might be a non-calcified mass that involves invasive carcinoma that we could biopsy at the same time as the calcs. It would be unfortunate if you localized only the DCIS and then at core biopsy all you saw was DCIS. But then when the surgeon did the excision, right at the edge, they found a little bit of invasive carcinoma and had to go back and do another surgery. So if you'd done the ultrasound first, you might have seen that and be able to do both. This turned out to be only DCIS, high nuclear grade. By the way, we are not very accurate in predicting the grade of DCIS based on mammography. It's just not that accurate. It's better than flipping a coin, but it is not accurate enough to be dispositive. I prefer not to suggest grade of breast cancer at imaging, because 20–30% of the time the pathologist will prove me wrong. So I just say it's suspicious. Let the pathologist say what the grade is. Then you get credit for finding the cancer, and you don't get, well, why is the radiologist thinking it's high grade when it's low grade, or vice versa? Okay. This is a seed localization, and I want to make a point here, because at the core biopsy, all that was found was DCIS. But at the surgical excision, and this is the specimen radiograph of the surgical excision, there was an invasive carcinoma, which you can see in the specimen. About 20% of invasive carcinomas, 20%, this is not 2%, 20% of invasive carcinomas present at mammography only as calcifications. So invasive carcinoma, calcifications. Well, there's probably DCIS along with the invasive carcinoma. And at the core biopsy, if it's a dense breast, you may not see the invasive carcinoma. So one thing to think about is whether you want to do ultrasound once you know there's going to be a biopsy. And the other thing to realize is that if you have a surgeon, the way we do, one of our surgeons at UCSF doesn't like to do surgery, prefers to follow things. So we'll look at this and say, oh, it's only DCIS at core biopsy. I don't have to excise it. I'll just watch it because it's only DCIS. And if she develops a mass later on, I'll biopsy it then. Well, 20% of the time, there's already invasive carcinoma. And you could take it out when it's small rather than waiting until it gets big enough to see at mammography in a dense breast, at which point she's no longer curable. So try to resist that. Understand that 20% number. Make sure your surgeons understand the 20% number if they're reluctant to excise DCIS. Okay. Case 7. Now, this is an asymptomatic woman. She's had a core biopsy for a mass, which was concordantly benign, which means that if we still see the mass, especially if there's a clip where the mass is, we know we don't have to worry about that as long as the mass is the same size as it was back then. Okay, so what do we see here? Oh, we see all sorts of things. This is going to be a confusing case, isn't it? Mike has a finger there. I saw that, Mike. He's seen something else. These are the MLOs. These are the CCs. When we see multiple bilateral circumscribed masses, we tend to immediately invoke what is called the rule of multiplicity and bilaterality. And what that means is if you see multiple instances of the same type of finding on both sides, that the overwhelming likelihood is that they're all benign. That is if, important if, all of them look the same. But if there's one that looks different than all of the others, then that's the one you have to worry about. Okay? Well, in this case, there's something that looks different than all the others. It's not even that subtle. All the others are circumscribed. This one is not. These are the full pixel resolution images. Looks like it could be a spiculated mass. Well, a case with multiplicity and bilaterality takes longer to interpret because you have to look at each one of the instances and make sure that they all look the same and that there's nothing that's different, that's the different tree from the rest of the forest, because that's the one you need to do the workup on. And anybody who didn't find this case, that's a very good example of what's called satisfaction of search. You know, you see something and you say, wow, you know, I looked at a whole bunch of normals and all of a sudden they're abnormals, and you look at the really obvious things and you forget to go back and look at something else which might be different. The way I try to avoid satisfaction of search is when I've got other findings, I just sort of cover them up with my finger. If they're really big, I got to use my whole hand. But if they're small, I cover it up with my finger, and then I look everywhere else. And then when I'm finished, I let go, and then I can look at the thing that I saw first. Often the thing you see first is not the important thing, because cancers are indistinct, but circumscribed masses are usually benign. So you're going to see the circumscribed mass first. Calcifications that are benign or coarse, you're going to see them before you see the tiny little ones that are cancer. So keep that in mind. Once you perceive this, the workup is pretty straightforward. You can see in this case that it's growing, and you can also see in this case that whoever read the 1 year ago, it's only a little bit different, but maybe that one could have been called. Do not interpret this one as enlarging suspicious mass, because that will be an invitation to a plaintiff lawyer to subpoena you to testify against whoever read that one, who is probably one of your partners, or maybe even yourself. So just say there is a spiculated mass. Don't say there is an enlarging spiculated mass. And the report that calls her back from screening. Okay, at Tomo, seen even better. Had we done screening tomo, we wouldn't have had to do these, and we just go straight to ultrasound, and you can see it as you would predict. So she's going to get sonographic guidance. This was invasive lobular, and that's a cancer. Our next patient is an asymptomatic woman, case 8. Here are our images, and the finding is that. This is a tomo case, and I am always challenged showing slides of tomos because I've still not figured out how to show the movies as smoothly as I would like to. So bear with me. But there is on the MLO view, not on the CC, but on the MLO view, suggestion of a little bit of architectural distortion. When you look at full pixel resolution, you see this line coming out here. There's one going there. There's one going there. It's sort of like the mark on a black widow spider, the hourglass with little lines coming out from it. You don't really see much on the CC. But architectural distortion, or even suggestion of it, should prompt a recall. But this is subtle, and you might not have noticed it. But if you did, you're going to recall her. And here's the movie, and if you look right where I have that dot, as the movie plays, there it is. Let's do it again. There it is. Now I'm going to try to stop it. There. Okay? I'm not going to even try this. All right, also on the CC, where we didn't see much, look right here. There. There. Now I can advance it and show you the frames of the tomo where you see it best. In cases of architectural distortion, you will always see it better at tomo than you did at 2D. You'll also see it better at tomo than at synthetic views if you use synthetic views. Synthetic views are poor man's tomo. The only reason to use synthetic views is if you don't get 2D images. Otherwise, they have less information than the tomo. But now you can see that there's a finding here as well, which you didn't appreciate at all. Take-home messages in this case, tomo for architectural distortion is always better. And number 2, if this case had been visible only on the CC, you might have missed it completely unless you had done tomo. And this is one of the reasons why at tomo, the cancer detection rate is a little bit higher, because it'll show architectural distortion cases where you might not have seen anything at 2D. All right, we can move on. Once you know where it is on the CC and the MLO, you want to find it on the true lateral so you know exactly where to triangulate, so you know where to do the ultrasound. You'll see it at ultrasound, know it's the same finding, biopsy it, and this was invasive ductal carcinoma and DCIS. And the next tomo case, I'm going to try to not get in the same mess that I did in this one. Okay, case 9. Here we go. Screening views. This is the breast, and that little thing is our finding. So this is a asymmetry, one view only finding. Don't really see it on the CC view. This is full pixel resolution. Looks a little concerning. You can't call it a mass because you don't see it on the other view. If it's a mass, it might be spiculated, or maybe it's just a focal asymmetry with a suggestion of little points coming out, which might be architectural distortion. But it's an asymmetry because you only see it on one view. So let's look at priors. Well, I don't see it 1 year ago, and I don't see it 2 years ago. This was a mark on some skin lesion. So do we know whether we should recall it or not? When you're considering recall, always look at older priors. Oh, we looked at 3 years ago, 4 years ago, 5 years ago, 6 years ago, didn't see anything, and when we got to 7 years ago, there it is. What does this mean? This means it's a summation artifact. See it, don't see it, don't see it, don't see it, don't see it, see it. You only see it when things overlap exactly right. If we were doing this workshop in a very small room where there are only a few of us and I could stand in front of the projector, I would hold up 2 fingers and align them and show you that as you move the 2 fingers, only when they're exactly superimposed do you see a single darker shadow. Well, with X-rays, it's a lighter shadow. But the same concept, it has to align perfectly. And for very small findings like this, it only aligns every once in a blue moon. But this is superimposed normal tissue, even though it looks spiculated. And you don't have to recall it, you're done. We will always check. One of the reasons I know it's 100% accurate is whenever we have one of these cases, like Mike said, I write the name down. And then I go back and look a year later, because she's going to come back for routine screening in a year, and then I don't see it again, and that validates that it isn't real. That's how I know it's 100% accurate. Okay. This one is asymptomatic. I'm just reading my notes to see where the finding is and what it is. This is a complex case. Okay, there's a finding here, and that would be a focal asymmetry. It wasn't on the other side. It's a multi-component focal asymmetry. Okay, it got recalled. Nothing else was seen about it during the recall. We didn't have priors, so this was put in probably benign. But what about the other breast? That was the obvious finding. That's the thing you'd see first. But what about the other breast? Well, she has another. Let's hit the right button. Another asymmetry, but this one's on only one view, and it's smaller. So the other one you're going to see first because it's bigger and it's on both views. But this is actually in a completely different place. The other one was over here. This one's way up there. So you might discount it as being, well, but it's a one-view asymmetry. You get a hint over here. Oh, I don't have my pointer on. Hold on. When we got out of it, I lost my pointer. Right over here, there's some little lines coming out anteriorly that suggest the possibility of architectural distortion. So it's maybe even an architectural distortion, an asymmetry with a suggestion of architectural distortion. So this is something you might want to think about recall. We didn't have priors, so she's going to get recalled. I didn't show you the full workup, but at TOMO, you can see that there really is distortion. And this is just an enlarged part of here, so you can see it a little better. There are lines coming out going this way, and this way. So there really is distortion. There's central opacity, which means it's just architectural distortion. It's not a spiculated mass, it's just distortion. And now we have to find it on other views. Here it is on the MLO, on the true lateral view. So we know it's real. We know where to look for it. Here we see it. It's got tiny, but we see it at ultrasound. I don't have it any bigger than this, but it's got angular margin. It's also got that echogenic rind that you saw yesterday. That's a new term in BIRADS, will be. This is suspicious at ultrasound. So we can do a ultrasound-guided biopsy. Hard to hit, but if you're good, you'd get it right in there. And that was a high-grade DCI. No, that's the wrong case. Forget that. That was a, where is it? Invasive ductal carcinoma. Tiny. That could have been a satisfaction of search case. If you didn't see it, you saw the contralateral focal asymmetry, which turned out to be probably benign, and it's still in surveillance, so we don't know ultimately what it'll be, but it'll probably wind up being nothing. The other side had a much smaller finding, less obvious, but that turned out to be the cancer. Case 11. Okay. This woman has skin lesions, dense breasts, and in this breast has calcifications. You're not going to see them yet, but maybe here you can see them a little bit better. They're right here, and they're right here. And if you're close enough, Mike, can you see them? Yeah, okay. Well, if you don't see them, you should be sitting next to Mike. On both views. She's going to get recalled. Here they are at recall on spot mags. Now, when you look at the morphology of these calcifications, they're mostly round. But they weren't visible on prior exams. Round calcifications might be considered to be probably benign. But if they weren't visible previously, you don't use probably benign because they've already changed. Remember, with BI-RADS 3 probably benign, prior exams will almost always change you from category 3 to either 2 or 4. If they weren't there before, it's a 4. They're already changed. There's no point in following them. They already changed. If they were there before and they were there for 2 or 3 years, they're benign. But in this case, they weren't there before, so they're suspicious, and they're going to get biopsied. And here they are removed. We got them. And this was high-grade DCIS. So again, these are subtle. If you didn't see them, maybe you didn't spend enough time on the full pixel resolution images. Remember that when you look at the full pixel resolution images on the workstation, that you have to be really concentrating as you go over each millimeter of breast tissue. And you're really not looking at millimeters, but you're not seeing the whole breast when you're looking at full resolution. You're looking at a little part of the image, then you have to move it over and look at another part of the image, and you have to concentrate as you do this. You have to use your macular vision, your central vision, to see fine detail. And if you're not concentrating, you can go right by it because you only have a few seconds to look at every little bit of the whole real estate of the breast. Okay, case 12. Asymptomatic woman. Not so dense a breast. She has a finding that's either an asymmetry or a focal asymmetry, depending on whether you think you can see it on the CC. I would call this an asymmetry because I'm not sure about the CC. So this is one where it could wind up being a superimposition. And more obvious here than here at full resolution. Here, there's a suggestion of architectural distortion. Here, it's just a vague blob, which doesn't look that different from other vague blobs, but we're concentrating on it simply because we saw this. So we're trying to find a correlate. We probably wouldn't have given that a second thought if there had been nothing on the MLO. All right. What about priors? Well, it seems to be getting worse. So this is going to Number one, make us think that it's real, and number two, be more concerned about it, so she's going to get recall. That's just so you can look at it without the circles. Here are the spot mags. We could just as easily and probably better done tomos. If there's distortion, tomos will show it better. But that's adequate. And here it is at ultrasound. And this was invasive ductal carcinoma. Okay? Questions? Oops, sorry, microphone. No, not seeing any hands. Yes, hand. Yeah. I wouldn't use any of those. I wouldn't. I would just say there is whatever. I wouldn't try to say things about temporal change, because what you put in the report, if a lawyer gets involved, and usually they won't, but if a lawyer gets involved, they are going to very carefully read your reports, looking for a little opening where they can, I know. That's one of the reasons why they want to get rid of the term developing, because we can't think, nobody's been able to think of a term. The developing is kind of vague, but nobody's been able to think of a term that couldn't be suggestive to a plaintiff lawyer that something was there before. So if you just call it a focal asymmetry and you don't say that it's changed, then they can't go back at you. You get that's part of the rationale. It's not going to be put in BI-RADS that way because that doesn't look very good. But because lawyers read BI-RADS too. I'd just like to say there is. That way you don't give any suggestion to a plaintiff lawyer that there's a reason to subpoena the person who identified the lesion and testify against the people who read it earlier. Okay. Case 13. All right. Okay. Mostly fatty breasts. Here are some calcifications. You're not going to see them until I show you that. This is an interesting case. These calcifications are not hard to see once you look at it at full pixel resolution. There's at least 10 of them, maybe 15. They're grouped. They're somewhat different sizes. Ordinarily, this would be of concern. We didn't have priors when we first looked, or did we? Let's see. No. It didn't have any priors. She did have a previous breast reduction, both sides. So you see post-surgical scarring, but now she's got calcifications. We don't have her priors. What are you going to do? Well, you're going to think about recall. But since you know that there were priors, she's had a breast reduction. She must have had mammograms before that. And who knows how many other mammograms she might have had since then. It's helpful to ask for those priors. They just might affect your decision of what to do about these calcifications. So, if you know their priors and you're contemplating a recall, and you don't have those priors, one of the things that I strongly recommend that you do is add in the management recommendations when you're recommending the recall, that your first sentence in the management recommendations be this: comparison with previous examinations may avert recall. We have a macro built into our reporting system, so whenever this comes up, and it doesn't come up that infrequently, comparison with previous examinations may avert recall. What does this do? It suggests that the patient shouldn't schedule her recall exam until we've had an opportunity to look at the priors. And that particular term, we have nurse navigators who help the radiologists get patients in. I don't know if you have that in your practice, but if you do, they're very helpful. They see that sentence, they're going to call the patient and they're going to say, the radiologist wants you to come back and have more pictures, but we also, more importantly, want to get your previous exams, because they may make it obvious that you don't even need to come in. So don't schedule your exam, but let's get the information about where you had your prior exams. If you don't know, ask your doctor. They can look up your report and they'll tell you exactly where they were obtained and when. And then we get them and then we look. Well, let's see what happened in this case. Current calcifications. 2 years ago, she had oil cysts with rim calcification. Well, you see that in fat necrosis, and you see it sometimes even a long time after the trauma. In this case, breast reduction surgery 12 years before. Sometimes it takes 8 years, 10 years before you see that, the calcifications. What happens to fat necrosis over time? If it's going to calcify, the calcifications usually increase, although they could also decrease, because calcium in the breast is like calcium in bone. It can get resorbed. The oil cysts may stay stable, or more frequently, they resolve, and the oil cyst gets smaller and smaller and smaller, shrinks and goes away. What's happened here is we had partially calcified, rim calcified oil cyst. It started, the calcifications got more, but the oil cyst started shrinking. And what happened here is the oil cyst is gone, and all we're left with are some of the calcifications. This is benign. Even though these calcifications are suspicious, we've got proof that this is benign. It's just oil cysts that went away with some residual calcification. So the prior exams did avert recall. When you get this, it's a BI-RADS 2. So remember, when you don't have priors and you're going to get a recall, add that sentence. Okay? Comparison with prior examinations may avert recall, or something like it, and have it worked into your system. Okay, case 14. MLO views, CC views. This is the breast of interest, and here's our finding. There's a one view only asymmetry. Very small. Very small. I just moved it over to the side like that. I was playing around with Photoshop and did that. And here are the priors. So here it is. Looks like it might be an oval mass if we were to see it on another view. Here, maybe. Here, even less maybe. So it looks like it either is a one-view finding that wasn't there before, or maybe it's something that's growing. We've had this situation before. This has to be recalled. She's recalled, and here's a tomo, and I'm going to skip the movie and show you that because I don't want to waste time with having my computer not do what I want it to. But when you look at the tomo and you get in just the right place, you are going to see a very small lesion. It's real. There is something there. And the fact that you do see a finding and that it wasn't there before, or at least it's getting bigger, that's going to prompt a recall. And here is the screening tomo that prompted the recall. And here's the diagnostic tomo where we see the same finding on an orthogonal view. This was a CC, this is a true lateral. We now have a mass. And it wasn't there before, so it's a growing mass. And that means we've got to find it at ultrasound. And at ultrasound, it's not typically benign. It's certainly not a simple cyst. Here, it's vertically oriented. It's taller than wide. It's somewhat irregular in shape on this image. This is going to be biopsied. Even though it's tiny, it's like 4 millimeters. And there it is being biopsied. This was invasive ductal carcinoma and DCIS. Tiny little lesion. This is an easy case to miss because it's so small. One of our radiologists was really good at the top of his or her game in order to find this thing. But that was a small cancer. And there's the clip in the right place. And this is just a seed lobe showing you the finding. Come on. There we go. Case 15. All right. Not so dense a breast. Ignore the skin lesion. There's a finding there, very small. In fattier breasts, it's easier to see smaller lesions. In a very dense breast, that probably would not have been seen until it got bigger. At full pixel resolution, it looks more like a focal asymmetry than a mass because it's got concave outward contour on both the MLO and the CC, maybe even a little interspersed with fat right there. Trying to get the pointer out of the way, but it's not going. And let's see what it looked like before. Well, we could see it before, but it looks like it may be getting a little bigger. So this is a real finding. We see it on 2 views. Looks like it's getting a little bit bigger. It's a focal asymmetry, so it qualifies as a developing asymmetry. Whether you use the words or not, this is a recall. Here it is at recall. It happened to get worked up with spot mags, and with spot mags, it is still there. It's still a focal asymmetry. There's some opacity in the middle, lucency in the middle, just like an asymmetry, a focal asymmetry, but it's getting bigger, and there may be some architectural distortion on the spot mags. Had we done tomo, probably would have looked even worse. But we don't really need to do the tomo once we have that. And here it is at ultrasound, also suspicious. And this was a small invasive ductal carcinoma. Okay. Case 16. This is another difficult case. I'm going fast because they're calcifications and you couldn't possibly have seen them. But the first thing that you notice in this case is this big focal asymmetry. Whoops. This, right here. This. You're going to see that way before you see tiny little calcifications. So what about that? Well, they decided not to work this up. They could have recalled it and worked it up. It probably would have wound up in the probably benign category because hopefully there's nothing there. Again, I hope we were right because it's a reasonably current case and we haven't seen her yet again. But on the other side, there, and hard to see, that's why there are dots around the circle, there are 2 very small groups of calcifications. On the MLO, there's some here and some here, and on the CC, there's some here and some here, the 2 groups. They're close to each other. So she's going to get recalled. Not for the other side, but for this side. By the way, when you're doing a recall and you ask to work up the calcifications in the left breast, look at the whole mammogram. Look at the other side. Maybe at the time when you're doing this workup, you see that focal asymmetry on the other side and said, yeah, they didn't call that back, but I think I'll work that up now. That's fine. That's good. And actually, when you do the diagnostic exam looking at one side, you're supposed to also go back and look at the other side as well and make sure you agree with the radiologist. So do that. I don't know. It wasn't done in this case, but it could have been done, and it might not have been a bad idea. At any rate, here she is recalled for calcifications. We're going to do spot mags. These are spot mags. And these are the full pixel resolution of the spot mags where you see the calcifications better. There's a little group here and a little group there. On the CC, there's a little group here and a little group there. These are fine pleomorphic calcifications, and that means inherently they're suspicious. So she's going to get stereotactic core biopsy. We got at least one of them. And that turned out to be DCIS. So presumably the other one is as well. And when she comes back for surgical excision, we're going to want to get the other one.
Quick hypothetical question.
Yes.
Going back to this case.
Yes.
Let's just say it was a baseline mammogram. You think that the focal asymmetry on the right side should have been recalled, but it wasn't. It was let go. She comes back a year later, and now you're reading it, and you see the focal asymmetry. It hasn't changed, but now it's only got 1 year stability.
Okay.
So are you going to recall it? Or are you going to just let it go? Because theoretically, it should be in a BI-RADS 3 category if you're
Well, it could be a BI-RADS 0 for the focal asymmetry that appears to be stable for a year, but that's all you've got. And you can do that. And if you think that it should be recalled, do so, but don't say there's a focal asymmetry that's unchanged from last year, but I'm recalling it because I have only 1 year stability. Don't put that in the report. Just say there is a focal asymmetry. And I wouldn't even put in the report there's no change. I just say there is a focal asymmetry. Let the next person who's doing the
Would you recall it though, or would you? I mean, I would probably just let it go.
I would probably let it go because they even were comfortable letting it go without prior. Okay. So I probably would let it go. But you have to think about that. And if you do it, don't get the previous person in trouble by making comments about stability. You had a question.
So when you biopsy that and it turned out to be DCIS, would that increase your suspicion for the contralateral?
Not a lot, probably not. When you have bilateral cancers, they don't necessarily manifest by the same radiographic finding. Like you could have calcifications on one side and mass on the other side. It happens. More commonly, if you have bilateral cancers, they'll both have the same feature. But it's not always. So it doesn't really help. The bottom line is when you're doing a diagnostic or when you're doing a subsequent screen and you see something that might have been there before, and that's not uncommon, just don't get the previous person in trouble by putting it in the report. Because if you do, and there's a lawsuit, and there may well not be a lawsuit, but if you do, and there's a lawsuit, you will be subpoenaed, and you can't refuse to testify when you're subpoenaed. And they'll ask you, because you put it in your report, they'll say, well, you mentioned in your report that this finding was unchanged from the previous exam. And they'll say, well, doctor, doesn't that mean that this finding that was suspicious in 2023 was also suspicious in 2022? And how are you going to get away from saying yes? Because you said it was unchanged. Well, you just testified against your partner. So don't say it. You don't have to say it. Your responsibility in reading a current exam is to say what should be done now. It's not to say what might have been done before. Okay? Let's do case 17. All right. Dense breast. Subtle asymmetry. A subtle focal asymmetry. Maybe there's something right there, and this one's even a little bit more vague, right in the center of the circle. Subtle. Noticeable more because when you look at the priors, there just wasn't anything in that location. But again, it's a dense breast, and positioning can be a little bit different, and things overlap differently. So this could just be, even though maybe you see it on two views, it still could be superimposed tissue. Just because you think you may see something on two views doesn't mean it's real. But you're thinking that it could be focal asymmetry. Well, look at the priors. Don't really see anything on the priors, either on the MLO priors or on the CC priors. If you had other priors contemplating recall, you'd go back and look, but we didn't have them. So we're going to recall her. We hadn't done Tomo, so we're going to do, wait a minute, which case number is this? This is we did do Tomo. And I'm going to not show you the movie. Or actually, I'll show you the movie and look carefully right where that circle is. There. Did you see it? Look right here. The movie will replay. There. Okay? Now on the CC, look right here as the movie plays. I'm not going to try to stop it. Actually, I'm trying to start it. Why isn't it moving? Well, I'm just going to move on. I can't get my pointer. All right. Where is my mouse? There we go. There. Did you see it? Let's play it again. Take a look. There. Okay. Now we get to see where I should have stopped the movie. And there's a finding there. It was very subtle on the 2D images, or the static images. But on the Tomo, it's much more obvious. This is why it's a good idea, if you have Tomo, to use it at screening. Because if you don't use it at screening, that was a very subtle finding. You may have gone right by it. But at Tomo, even if you did go by it on the static images, you're not going to go by it on the Tomo. So if you want to look on this case, the MLO frame was 42 out of 75, and the CC was 42 out of 76. So it's right in the middle. And there's clearly a finding there. On the MLO, it looks more distorted than on the CC, but there's something there. And this is going to be a recall. And these are spot Tomos at recall. Could have gone straight to ultrasound, but they got spot Tomos on recall. Spot Tomos, like any spot compression view, is going to show you the finding in greater detail, because you're getting better compression with the spot. You're pushing it closer to the image receptor, so you're getting better, less geometric blur. It's just going to look better. If you're unsure, you just want a better picture. And once you know where to look for it, find it on a true lateral. And I don't know why they did spot Tomo and MLO. They should have done it in true lateral, but maybe they did and I just didn't take a picture of it. But you figure out where it's located, find it on ultrasound, biopsy it on ultrasound, and this was invasive ductal carcinoma. That's case 17. Okay, why did I show? Oh, just post-core showing that's the place for it. Remember that tomo is a better mammogram. And if you have it, use it. In my opinion, it is valuable both for screening and diagnostic, but it's especially valuable at screening because screening gets you in the ballpark where you're working up the finding. If you save it only for diagnostic, yes, it's helpful, but you're missing out on early diagnosis. So I would start it with screening and work in the diagnostic later when you get your next tomo unit or however you want to do it. Case 18. Okay. The time I see on the timer is, oh, he's not even there. We're a little bit over, but we have time for questions at the end still. I'm supposed to be doing questions, but first we're going to do the last 3 cases and then we'll do questions. That's why we planned it with extra time. Okay, she's asymptomatic, case 18. And here, this is an interesting case. Not a particularly worrisome case, but an interesting and instructive case. By the way, take note, just briefly, you see this little line here? That's a radiopaque marker placed over a skin lesion. It just got partially included in the image field. We'll come back and talk about that in a few minutes, in a few seconds. There's a finding here. When you look at this finding up close, it's irregular, and it has this bizarre dark area in the middle. That looks like air. How did you get air inside the breast? That would be really difficult. Could it be a skin lesion? Well, yeah, but why did the technologist put a marker over something else in a totally different part of the other breast and not put a mark on this? Didn't notice it. Why didn't she notice it? Because when we recalled her and we had them put a mark over it, they had to lift up the breast and move it over to the side because of the keloid in the inframammary fold. So bottom line, when technologists are putting skin lesion markers, they have to lift up the breast and look underneath. Because if they don't do it, you're going to wind up recalling for skin lesions. And this is what we had to do in this case. So it's a simple case. There's no cancer there. But the technologist could have averted the recall by simply lifting up the breast, noting the keloid, putting a marker on it, and then we wouldn't have recalled her because we would have had those pictures.
So I'm curious because this is one of the cases where I thought, well, I guess I went down the tubes on it because I don't see anything. But I would not recall it because of the air.
Okay. If you're confident that it's air, you could do it, but it looks so irregular that, why couldn't it have been a cancer that was fairly close to the skin that actually grew out to the skin and caused a finding? The patient never noticed it because she doesn't lift up her breast and look underneath there in the mirror. So we recalled it. But you could have, but I would have preferred seeing such an irregular finding, even with the air. You suspect that it's on the skin. And when we recalled her, the first recommendation we made is lift up the breast and put a skin marker on anything you see before you start taking other pictures. And these are the only 2 pictures they got during the workup.
That dovetails into my next thought. I get the impression you guys don't do tomo on your routine screen.
Yeah, it probably would have, yes. That's not true. I don't show most of my cases as tomos for 2 reasons. The first reason is that not all of you do tomo. And for some of you who have tomo, you don't do it on screens. And I'm showing you screening exams. Number two, there's some people who don't have tomo at all. And they're not going to want to spend an hour and a half looking at cases that they don't even have access to. It'll just make them want tomo more.
That's fair.
So that's why I don't show them. And the third reason, which I don't like to talk about, is I'm really bad at showing movies. But yes, if you have tomo, you should be using it at screening, and you should try to get it on all your machines. The sooner the better. I realize you don't want to get rid of a perfectly good machine until it wears out, but when you replace it with a tomo unit. Okay, that was a simple case where the technologist could have helped. If you have sessions with technologists, and I recommend that you do, where you teach them how to do things better, this would be a case to show. Because, and without blaming a specific person, saying, you know, here's a case where the patient got recalled simply because the technologist didn't go and take a look. It only takes a second. And they're manipulating the breast anyway to position it. Okay, case 19. Here we are there looking at calcifications. So you'll see them better at full pixel resolution. Right in the center of the circle on both views. At full pixel resolution, they're visible but not that visible. And these calcifications are nowhere near where these are. How do we know that these are nowhere near these are? Because we don't see them on the CC. Right. They're in a totally different part of the breast. They just happen to overlap here. But these are the ones of interest. They're subtle, easy to miss. It says they're not present 2 years ago, 1 and 2 years ago, meaning I didn't show you the pictures because there'd be nothing to see. So we had the priors and they just weren't there. So they're new calcifications. What does that mean? It means you got to worry about them and they're in a group. So you're going to recall. Here's the recall. Here are the spot mags at full pixel resolution. You can see them much better. They're mostly amorphous, and amorphous calcifications are some of the least worrisome calcifications, but they're still BI-RADS 4B because they have about a 20% likelihood of malignancy. So they need to be biopsied. And here they are at biopsy, and we got both of them. No, we got, yeah. We had only one group, but she actually had two. That happens sometimes. That means the second group we didn't even see. Now, it was there. We didn't work it up. We didn't do spot mags because it wasn't seen. And here are the post-core pictures, and the answer was high nuclear grade DCIS, but subtle calcifications. If you're winding up having trouble seeing these calcifications on the workstation, and that's possible, you need to change your search approach when you're looking at the full pixel images. You need to spend more time than you're spending because you're just missing calcifications. That means don't just try to look, gestalt looking at the whole image, but concentrate just on the center of your viewing area and look all over from top to bottom of the image, then move it a little bit top to bottom of the image so that you're using your macular vision looking for these calcifications. Okay, last case. Asymptomatic woman, she's had a lumpectomy on the right a year ago. So this is the lumpectomy side. That's where her scar is. You're going to want to make sure the scar is not getting bigger. But in this case, the finding is in the other breast. as it sometimes is. And there it is. There's a little focal asymmetry, looks more like a focal asymmetry than it does like a mass. But we see it on 2 views. No calcifications, no distortion. What about on the prior years? Well, it's more obvious, and it's maybe bigger. And that needs to be worked up. A woman who's had a breast cancer on one side is at higher than average risk for getting a breast cancer on the other side. Okay? It wasn't called. We read it as negative. If you got this and we didn't get it, you did better than we did. Because when she came back a year later, she was still asymptomatic. It was bigger, much bigger.
Well, we could have gotten it on current, because I did notice on current, because we know that this is a case that every one of these has cancer. We're like, where's the cancer?
Well, I don't mean for you to look at these knowing they all have cancer. Case 18 didn't have cancer. It was a keloid. Some of them were superimposed tissue. They don't all cancer.
I figure I missed it.
Yeah. No, but this is a case where we missed it. And you're going to have cases where you miss it too. Now, I show you this case for the medical legal reasons and also to show you that we're not perfect either. So don't expect anybody to be perfect. But it didn't change much here, but this is only a year and it had a big difference. So you think that we're going to get sued over this one? Well, the answer is we're not going to get sued over this one. And the reason, even though it's big and obvious, remember her history. Okay, number one, she's 81 years old. Lawyers sue if they think they can make money. They don't sue to win the case. They sue to make money because they get a third or some big percent of whatever is collected. They're not going to collect a lot of money on an 81-year-old woman. She's got a life expectancy of like 9 years. And she's not working, so she's not earning any money. So there's no damages that they're going to want to take the case. Number two, it just so happened in this woman that she was treated with lumpectomy and they decided not to do anything else but the lumpectomy because she was 81 and she had comorbidities. So if they decided to simply do a lumpectomy on the other side, what are they going to do on this side? They just did a lumpectomy on this side and didn't treat her with anything else. So there's no lawsuit because there's no damage to the patient. She got treated the same way she would have if it had been diagnosed the year before. So the answer is, in this case, even though it was a below standard of care interpretation, there's not going to be a lawsuit. Okay, well, thank you for listening. I hope you enjoyed it.